All right. I got 12:01, so let's go ahead and we can get started. So, welcome back, everybody. If this is your first time, welcome. If this is not your first time, then thank you for coming back for our continuing professional development series. So, in today's session, we are going to be covering upper limb orthotics and prosthetics. And we'll share how we're currently approaching these topics, but we really want this to start a conversation. So, we hope that you guys will unmute and interact and kind of give us your feedback as we go. A little bit of housekeeping. So everybody should have received the link to the post-session survey in the email that went out yesterday, the reminder email. In that email, you'll also find the folder where we put all of the recordings for the CPD sessions. So just make sure that you go ahead and take the survey within 30 days so that you can get your CEU credit. You can take it afterwards, but you just won't get the credit. So make sure you do it within this next month or so. And then likewise, we have 2 more sessions in this series in September and October. If you can't attend those in person or synchronously, then you can go ahead, watch the recording asynchronously, complete the quiz, and still get your credit. So with that, we will go ahead and get started with today. So I'm excited to introduce Jeremy Sherman, who is going to be one of our presenters. Jeremy is an assistant professor in our program, and he's the associate director of curriculum. He's also the course director for upper limb prosthetics, so he'll be covering that. And my name is Megan Glon Castile. I'm also an assistant professor in the program, and I'm the course director for upper limb orthotics. So with that, I'm going to go ahead and share my screen and get us started with ULO. All right, so we hope that at the end of today, you'll have a good idea of what topics we are covering in both ULP and ULO. We want you to be able to compare what is currently being taught versus what is currently happening in practice. And we want you to be able to reflect upon the educational standards and the ways in which we are teaching and how that is aligning with our practice. Now, like we said earlier, this is very much so meant to be a conversation starter. We are not going to be able to cover everything that we cover in ULO and ULP, but really giving you some of the highlights and then getting the conversation going from there. So with that, I will get started with upper limb orthotics. So I wanted to start off by showing all of the competencies that we're covering in ULO. So these are some of the general ones. I'm not going to go through all of them. But if we go more into the actual upper limb competencies, we're covering finger, wrist, elbow, and shoulder injuries, deformities, disorders. We're covering rotator cuff injuries, adhesive capsulitis, dislocations of the upper limb, contractures, brachial plexus injuries. And then we're also covering a wide breadth of devices as well. So our students are going to have experience with finger orthoses, hand orthoses, HOOs, elbow orthoses. The list kind of keeps going. But I want to bring your attention to the last 4 items on this list. So all of our students have to custom fit prehension orthoses, so like a wrist-driven tenodesis. They have to custom fit a shoulder, elbow, wrist, hand orthosis, a fracture orthosis, and then they actually have to custom fabricate either a wrist hand finger orthosis or a wrist hand orthosis. In our curriculum, we actually custom fabricate 2 devices. So the first is just your classic resting splint, so a custom wrist hand finger orthosis. But then we also introduced CAD/CAM into this curriculum. And so our students are currently creating a hand orthosis via that. And we'll talk about that in just a few slides as well. Now, these are the textbooks that we are using in upper limb orthotics. I would say we heavily rely on the Atlas for the most part, but we also have the orthotics and prosthetics and rehabilitation textbook as well. Now, when we were brainstorming what we wanted to cover in these CPD sessions, we had sent out the survey to get your feedback about what is really happening in practice for all of these different topics, with which, of course, asked about upper limb orthotics as well. And so the feedback that we got regarding upper limb O is that basically it's rarely done in practice. textbook ULO is not really making a big presence in practice. And so that leads to a little bit of a challenge when it comes to teaching ULO. I always tell students that within the first year of the program, we are going to teach you what the box is. We're going to teach you all of the textbook indications, all of that, all of the biomechanics. But then a lot of times when you get out into practice, especially when it comes to ULO, you might be doing some really simple devices like just your basic prefabricated wrist hand orthoses for carpal tunnel. Or you might really be thinking outside of the box with these very intricate custom fabricated devices that are not found in the textbook whatsoever. So I think these devices are really fun because you get to be creative and problem solve a lot, but you're not exactly going to find that wrapped up in a textbook chapter. And so it's a little bit challenging to teach what's within the box, but then also to encourage the students to look outside of the box as well. And to give you a little bit of background info about how ULO appears in our curriculum at Baylor. So for the last several years, ULO has actually been the first core device-based class that is taught during the didactic year. And so what that means is that we have had to really start from scratch. We have had to teach what is off the shelf versus custom fit versus custom fabricated. They haven't gotten any insight into materials yet, so we have to cover high temp versus low temp plastics. They haven't had their anatomy course yet, and so we have to go through anatomy, especially neuroanatomy, which I'll talk about in just a few minutes. But that really comes into play when we're talking about upper limb orthotics. And then they don't know anything about coding or insurance or case recommendation. So we are really starting from scratch and building their knowledge base, not only for upper limb orthotics, but also for the rest of their device-based classes as well. So that's how we've been doing it. Now, this year, so for our class who will be graduating in 2027, ULO is actually going to be one of the last classes that is taught, and it's going to be taught alongside upper limb prosthetics. And so I won't get ahead of myself, but that background information is important for where we're going next. Now, some of the big topics that we cover regard spinal cord injuries and a lot of brachial plexus injuries, along with peripheral nerve injuries. So neuroanatomy really does come up quite a bit in our curriculum. And this is often an overwhelming topic to get the students to truly digest and understand and appreciate. And so for teaching myotomes, I absolutely have to credit Ashley for teaching us when I went through the program, the basketball dance, and that helped me learn our myotomes. And so I've stuck with it ever since. And so what this little dance looks like, it helps us remember all of our myotomes. So for C1, C2, you're doing your neck stretch, you're getting ready. C3, you're going to stretch going the other way. So you have that lateral cervical flexion. C4, you're starting to get your shoulders ready to make your shot. You have your shoulder elevation. C5, you're going to start to get ready to really take your shot, but you're not there quite yet. So at C5, we have shoulder abduction, shoulder flexion, and some elbow flexion. But when you get to C6, this is when we're really ready to shoot our basketball. So you have strong elbow flexion, and the big thing that we have is wrist extension. And this is going to come back into play in just a second. So this is C6. Then for C7, we go ahead, we get elbow extension as we shoot our shot. And then we also get our wrist flexion. Awesome. We made our shot. So then we go ahead, give ourselves our thumbs up. We get that thumb extension, and we also get finger flexion. And then finally, we high five a teammate. And so we get that finger abduction at T1. So this is one of the things that we use to help teach our students the myotomes. And that then sets the stage for teaching spinal cord injuries. So with our spinal cord injuries, of course, the higher levels are going to need more of positioning devices. And then as our patients gain a little bit of mobility as we go lower down with a spinal cord injury, we might be moving from more positioning to more of these functional devices. So with our C1, C3 tetraplegia, we're really just looking at positioning. So we're going to be using a long opponents to keep the wrist, the hand, and the fingers all in a good position to prevent contractures. When we start to get a little bit of shoulder mobility back at C4, especially at C5, that's when mobile arm supports start to come into play. But then we're also going to need the positioning devices down at the wrist, the hand, and the finger. When we get to C6, this is a really important one because at C6, wrist extension comes back. And with wrist extension, what we can do is we can get wrist-driven tenodesis into the ball game. And so with a wrist-driven tenodesis, we capitalize on that wrist extension to create a grasp. And so that gives our patients the ability to grab items. Otherwise, they would really not be able to use their fingers and their digits to manipulate items in space and to be functional. And so really, when we get to a C6 spinal cord injury level, we're starting to look more at function. Now, I have this highlighted and bolded on the slide because this is something that comes up on pretty much any exam that we are giving in ULO, and it also comes up a lot, not only in practice, but also on board exams and in testing environments. But the C6 wrist-driven tenodesis, that is one of the big things that we try to hammer home during our upper limb orthotics course. Now, as we get down to C7 and C8 and T1 spinal cord injuries, again, these patients are starting to get a little bit more independent. And so we're moving from more positioning to more functional devices. So C7, we're still looking at a wrist-driven tenodesis. And then C8 and T1, we might really only need a short opponent just to kind of maintain the web space of the thumb. Now, moving on to our brachial plexus injuries. So we cover flail arm, Klumpke's palsy, and Erb's palsy. So with a flail arm, that is going to be a C5 through T1 total brachial plexus injury. So really our orthotic goals for a flail arm is just to stabilize the shoulder and promote function as best as possible. A lot of times these patients can have a lot of pain, and so we want to see if we can stabilize the shoulder in its joint. So our orthotic interventions are often going to be slings. The Wilmer carrying orthosis is really popular. And then if our patients are down for it and really committed to their rehabilitation, we could also look at a Stanmore flail arm orthosis, where we're really incorporating a lot of prosthetic componentry to utilize that flail arm as best as we can. Now with Erb's palsy, this is going to be an injury of the upper trunk of the brachial plexus. So these patients are going to present with what we call the waiter's tip position. So their shoulder is going to be internally rotated, their elbow is going to be extended, and then their wrist is going to be flexed. Now, in terms of our orthotic intervention, especially right after the injury, a lot of times we're providing an airplane splint. Especially in our young patients, this is going to be the common approach. Older patients as well, but they might be a little bit less tolerant of these big devices. And after we get through that acute phase, we're really treating the presentation that is in front of us. Now, for Klumpke's palsy, this is going to be an injury to the lower trunk of the brachial plexus, so to C8 and T1. Now, if we think back to our basketball dance, we had C8 and then we had T1. So with these myotomes, we're really starting to get into the intrinsic muscles of the hand, so our lumbricals and our interossei. Now, those muscles are really important in creating MCP flexion and finger extension. We call them the bye-bye muscles. And it's nice because this shape looks like an L, L for lumbricals. It's an easy way for our students to remember that. But if you think that if we have an injury to the muscles that allow us to do this motion right here, then the opposite is going to happen if we can no longer use these muscles. So we're going to get MCP hyperextension and IP flexion. So any orthotic intervention that we provide, we want to limit that MCP extension, reduce that hyperextension, and then we want to promote finger extension as well, reducing that finger flexion, so getting them out of this claw hand position. So as you can see, as we're going through these different things, neuroanatomy really does play an integral role in our ULO course. And again, that is important because we're going to get there in just a second. Now, moving on to our peripheral nerve injuries. We talk about radial nerve injuries, median nerve injuries, and ulnar nerve injuries. So with our radial nerve injuries, these patients are going to have a hard time with extension, pretty much all up and down the arm. So depending on the level of the radial nerve injury, they might have trouble with even extending at the elbow. But if it's a little bit lower on, then they might have trouble with extending the wrist, the MCPs, and the IPs. So our orthotic intervention is going to stop that excessive flexion and really assist with extension in any way that we can. Now, with a median nerve injury, these patients are going to present with the hand of benediction. So whenever they try to make a fist, they are only able to flex digits 4 and 5. They lose the ability to flex digits 1, 2, and 3. And so we lose the pronators, the finger flexors. We also lose thumb abduction, but we don't lose thumb adduction because adductor pollicis is actually innervated by the ulnar nerve. So in our orthotic intervention, we want to make sure that we're encouraging not only that MCP flexion and IP extension, but we also want to prevent excessive adduction of the thumb. So that's something important for the median nerve injuries. With our ulnar nerve injuries, these patients are going to present almost similar to Klumpke's palsy, except we're only seeing that clawing of digits 4 and 5. And that's because the lumbricals of 4 and 5 and the interossei are innervated by that ulnar nerve. And so again, when we lose the ability to do that bye-bye motion, we see the opposite happening. So our intervention needs to block that excessive MCP hyperextension and promote that IP flexion, or extension, excuse me. Now, that is kind of covering the highlights of our nerve injuries that we talk about. But in our course, we also bring in 2 guest lectures. We have James Northcutt, who is an OT at Texas Children's. He is absolutely phenomenal, and he comes in towards the end of the course. He and Dr. Gogola both come in towards the end, and he really encourages the students to think outside of the box. He has a lot of fantastic case presentations where he is just doing all kinds of trial and error. And I think it's really comforting for the patients to see that sometimes, or for our students to see that sometimes it takes a lot of trial and error with patients to be able to get it just right. And James, he's a certified hand therapist. He has been doing this for a long time, but sometimes he will be the first to admit that what you try first, second, sometimes even third is not going to be the best route for these patients, and we have to keep trying. And so really love having him come in. We also have Dr. Gogola come in. She is a pediatric hand surgeon at UT, and she has a ton of experience with all types of congenital anomalies and does a fantastic job just really highlighting all of the different presentations that our students might be seeing out in practice, especially in the pediatric setting. She's done a lot of work with arthrogryposis, and so she covers that extensively, and both of them are really just great additions to our course. And like I alluded to earlier, our students also use CAD/CAM for one of their projects. So we make a custom hand orthosis. Scanning, we are using the Comb app, so all of the students get their own license and they're able to practice on each other. For modifying, they've been using Spenties, at least that's what we used this past year. We might use a different software this year, but we actually found the Spentie software to be very intuitive, and so it worked out well for this project, especially because it's so early in the curriculum. And then we actually printed the hand orthoses using our own printer at BCM. So this was a really good project. Each group of 4 students ended up printing out 1 hand orthosis, so they fit them all as a group. But this was our way to introduce this newer technology into the curriculum and also get the students excited, because a lot of them come in with biomedical engineering backgrounds and they want to see 3D printing used in action. And so this was a great way for us to easily introduce it into our curriculum. But now, honestly, I want to hear from you guys. So, with the move of ULO from the very beginning of the program to now basically at the end of the didactic curriculum, we are going to have a lot more time on our hands. We're not going to have to cover neuroanatomy as extensively because they've already been through their anatomy course. They've already done a ton of other coursework, so we don't have to cover all of the basics anymore. And so I would love to hear from you guys about what areas you feel like we can really elevate our ULO curriculum. And to help get the conversation started, I am thinking about bringing in MyoMel so that they can discuss the MyoPro and some of their other devices as well. Thinking about maybe doing some low temp lab activities so that they can get a little bit of experience with that. Hopefully we can kind of team up with James for that as well. But if anyone has ideas, any cool things that you're seeing in practice, anything that you feel like you did not get enough of in school but would like to see more of. And the chat is an option as well.
Hi, Megan.
Hey, Amanda.
I think those two recommendations of getting experience with low temperature thermoformable splints would be really nice because I did have a professional athlete come in with a prescription for one, and I didn't know and or have the material to do that. But I also think we just delivered a Myomo last month, and they were awesome, and those OTs really know what they're talking about. So I think that would be a good kind of put icing on the entire course thing.
Beautiful. I think we have one hand up. And then I
Yes,
think
Megan.
ah,
Since there is an overlap, I'm Yusuf Salam from the Middle East, and I do trainings in the Middle East and Eastern Europe. So since there is an overlap between the occupational therapist and the orthotics and the upper limb orthotics, what I suggest teaching is the more advanced orthoses, things with like, dynamic, maybe pneumatics and so on. That's a little bit more exciting to the orthotist, but it's not really practiced on a daily basis by the, the occupational therapist.
mm-hmm.
So maybe this is something that would attract the students more to something that they don't see regularly, with the other practices.
Yeah, absolutely. Thank you. And I know Jeremy in upper limb prosthetics has done some um, interprofessional development days with OT students. And so thinking about maybe there's a way where we can all work together for both O and P on those days as well. And then I think I saw something in the chat. Let me see if I can find it here. Do you have a fitting lab where students practice fitting off the shelf who's Sarmiento's post-op shoulder immobilizers? Yes, we do. It's normally about a 3-hour lab or so, and so they'll work around the different stations and go through all of these different devices. We have a ton of samples actually in the lab. I think the only other idea I have at this point, and please, if you think of any later, feel free, shoot me an email, is seeing if we can get some sample Benic devices and practicing with those, like heating them up, really forming them to the patient, because I know, at least in the pediatric setting, I used to do that quite a bit as well. Okay, thank you guys. Well, with that, I will go ahead and toss it over to Jeremy.
Thanks, Megan. That was great, and I will look forward to going through ULP now. So I'm just going to share my screen. There we go. Figure this out. All right. So for those who didn't hear before, my name's Jeremy. Graduated from the program in 2016, and I'm currently Associate Program Director for Curriculum, and I teach, as one of the courses that I teach is upper limb prosthetics. This is my second CPD for this course. for this set of CPDs. My first one was hand skills, and I think I'm also doing the next one with lower limb prosthetics too, so transfem. So if you're interested in that. But I'm going to go through upper limb prosthetics the same way that Megan just went through upper limb orthotics. Like she said, really can't go through everything that we teach in the course. There's just not enough time here, obviously. But feel free to take screenshots or take notes, jot down whatever you need, and happy to answer any questions afterwards. So textbooks for the course, as you guys know, for upper limb prosthetics, there is not the most information out there. We rely a lot on published information as far as our socket design and development and everything, but we do use the atlas. I also have K-Hub competencies here, so what the class goes through. I know that nobody is going to read that or be able to read that. This is something that students get in their syllabus and we use during our accreditation. So I'm just going to skip past that. But really, what you guys are interested in, right, is what will the students have done by the time they're through this course. So non-patient experiences, or basically experiences that they can simulate with each other. They will have made body-powered bypass prostheses, meaning that they have made a transradial device, body-powered on themselves, so they actually just cast around and work around the hand. It's not unique to us at Baylor. A lot of programs do this. And then they're able to utilize that body-powered device during a prosthetic training occupational therapy lecture that we have. So they get to work with it while being trained on how they would work with patients. We do 2 brim projects in the class. So the contours that are necessary for fitting a lot of these sockets are really important, especially around joints. So our transradial anatomically contoured brim, where you actually have to extend above the elbow, they fit each other prior to actually doing that with patients. And then they do a transhumeral brim as well, where they cast each other and make the wings to a transhumeral device. They make a transhumeral body-powered simulation. This basically is they will simulate having a transhumeral patient with a dual control harness with a locking E400 elbow. We use that both to get across the concepts and ideas of force and excursion problems and everything that's necessary in transhumeral. And we use it in practical exams as well. They also, thanks to OSER donating materials, they do get to do partial hand castings on each other. So they get to work with silicone material. They also get to see alginate. So they've tried that as well. So that's all with each other or simulated. With patients, we bring in transradial patients. So they get to see them once to cast them. They're casting them for a transradial anatomically contoured socket. Have some pictures of that later, but they basically do an anatomically contoured, anatomically suspending socket. They then do one fit with those patients. So they do a skin fitting, it's PETG socket, and they do myo testing at that point. And then they take the best fitting socket from those days, and every patient has 2 sockets that are made from that, where they will come back in, and the students get to fit them with 1 socket that has been set up for a dual site myoelectric control, and 1 socket that has been set up for pattern recognition. So the students actually get to try both back to back. They get to work with the patients and to see how they would train them and how they would work through basically educating somebody on how to utilize dual site, and then move right into, okay, what are the differences now if I put a pattern recognition on them? For that, we do have a lot of content experts that come in. I'll get into them. Like Megan talked about, in order of courses, ULP is one of the last courses. It's our last device-driven course. So the goal with it is that the students are more independent with their fabrication projects. The projects require less time. We work on getting them to work on efficiency and get through the lab quicker at this point. And it gives us time for more of those content experts. I have pictures of the content experts on the next slide, but essentially we bring in occupational therapists and manufacturers are some of the big ones, as well as certified prosthetists. One thing that really came up in the survey for ULP beforehand is people were kind of keying into this is something that you need to be able to reach out to people and you need to be able to rely on the experts because we just don't see enough of this out in clinic, right? And so we try to introduce that to the students here and get them used to reaching out and used to working with content experts. So the people that we bring in, I think since the inception of the program, Sean Swanson Johnson has been coming in. Just a quick plug for her. Skills for Life is going to be here in October, here in Houston in October, and is looking for volunteers. So if you want to know more about that, contact me. But Sean comes in. We have Christy Powell has also been coming in for the majority of the time the program's been open. She works with OSER, and she talks with our students about transradial, partial hand. Chris Bashik, this was his first year coming in with us, and he's Director of Clinical Services at Point Designs. He talks about partial hand with the students. They had a full half day with him this year. Nate Sprunger works with PhilHour. He's the director of their clinical education. He comes in. He's one of the experts that helps them fit on their patient day, where they get to fit both dual site and pattern rec. Rahul Kaliki comes in. He's with IBT, so gets to talk some more advanced items, including the Glide system. And Kate Winslow, so we have somebody come in from Co-opt, and really, so we have experts that they're able to rely on for all of these things. So the next little bit that I'm going to go through here, I want to talk about what the students get as far as content. I know that, again, people might glaze over. It's like being in class, but I really think it's important that you understand what they've learned throughout their time here. Again, this is not everything, but some stuff that we go through with the students. So we go through the levels of amputation and everything that is specific to those levels that we want them to know. But we go through partial hand, wrist dysartic and transradial, elbow dysartic and transhumeral, and then our shoulder dysartic patients. We go through prosthetic options, all kinds of prosthetic options. Students are taught that basically having no prosthesis is a valid option. It does not mean that the intervention was unsuccessful if somebody chooses not to have a prosthesis, especially in the upper extremity population. We talk to them specifically about not having a cosmetic device, but it has to be cosmetic functional or really just a functional restoration and really focusing on function if they're looking to actually get these things paid for. We talk about activity-specific devices. And then whenever we're looking at powered devices, we spend a lot of time with body power. But again, as we were talking about with the patient fittings, they get to fit, and we spend a good amount of time with myoelectric as well as when you would hybridize. We focus all of this in on basically the practice analysis determines how much time we spend with these things. So it's not a large portion of what we're seeing, but that's why we spend the majority of our time with body power, followed by myoelectric, and we spend a lot of time with harnessing, and the students fit anatomical suspension whenever they're fitting with their patients. We do go through, and again, for transhumeral and elbow dysartic, passive or aesthetic, and harnessing we get with our simulation. And then the majority of what they're going to see is hooks. So that's the majority of what we use. Whenever they come in and the content experts come in, they get to fit eye-limbs of multiple types, as well as TASCA, or really the externally powered multi-articulating hands that they get to use. But the majority of what they see and use are hooks. Challenges that we talk about in upper extremity. So the percentage of care that it is. So if we're looking at the time spent in practice areas, upper limb prosthetics is about 8.8% according to ABC, which is pretty similar to partial foot. So you're going to see right around the same amount of upper limb patients as you're going to see partial foot patients. So even as it is, we spend a long time with something that is not a huge part of clinical practice. We talk about managing our patients' expectations in all of our classes, but very specifically in upper limb. Patients come in and they're expecting to be, I forget this guy's name, but they're expecting to have something that is cool and they see in cartoons and they see in movies. And we show up with something that looks like it's straight out of the 1900s. And working through that is a challenge. And we also talk about the golden rule, published by Malone in 1984. It's not, the be-all, end-all, but basically the time to fitting our patients. In upper extremity, we're worried about somebody becoming one-handed. In lower extremity, we're never worried about somebody becoming one-legged, essentially. So it's a unique challenge to upper extremity. We also talk about the predisposition to reject these devices, which can be led by a whole host of different things. You're more functional without it. You become one-handed. It's too hot. It's too heavy. It's uncomfortable. The differences between congenital and acquired amputations. We spend more time, and we're actually emphasizing this more with a new course that's coming in this next year. But on coding and reimbursement, I mean, the codes are evolving, thankfully, for upper extremity. As of April 1st, right, we got new codes for partial hand and a couple of revamped codes. So we really try and lean into making sure students are also very, very timely with their knowledge. Socket designs that we go through. So they learn to fit the track, so the transradial anatomically contoured socket, but they learn traditional styles as well. It's good for board exams. It's also good to know, right, where all this came from. So they learn about the Munster, the Autobach, and the Northwestern. They learn about solder style, so cutting out what's not needed, 3/4 sockets, but we really focus in on the track. For transhumeral, we talk about the dynamic socket, the Utah dynamic, and then those still hi-fi IE sockets. Again, they get to do a brim on each other for this, and they get to do a simulation, but they don't actually fit a transhumeral patient. Again, you guys can take screenshots. I don't know if anybody needs any of this as a refresher. We go through, like I said, a lot of time with harnessing. So we have our transradial and transhumeral systems. A lot of this is really intended to be kind of a review. So if the students get out into clinic and it's been months since they've seen their last upper extremity patient, they have this that they can go back to. So reviewing, okay, I need to order stuff. I have a patient coming in. What do I go and order? What are the components that go in? Knowing the nomenclature is huge. We talk about body-powered harnessing, both kind of traditional figure 8, figure 9, what they provide and how to create them, as well as going through harnessing alternatives. So whenever we're going to do an axilla bypass, or we're going to use basically a shoulder saddle, or if we're going to go to a full like Martin Bionics system, or so. They're, again, given these reference materials. I don't expect anybody to read all of this, but it's all stuff that students will have whenever they're leaving the first year, that I fully expect them to take in and maybe not touch until an upper limb patient is coming in. So I encourage you guys as preceptors, whenever you have an upper limb patient coming in, to really rely on the student and say, like, okay, go look at your reference materials. What do we need? What should we be looking for? So here we have a whole lot of our landmarks and what they mean, how much excursion is required to utilize our individual componentry. So to open a terminal device, we need 2 inches. To actually flex an elbow, we need 2.5 inches. Together, we need 4.5. We want to actually flex an elbow and open a terminal device together. And what motions are necessary for this, how we get our alignment, our Carlisle formulas, So we can actually take a bilateral patient and make the sections of the arm the appropriate lengths. After this, I swear there's only one more set of tables. We talk about how to validate that they've actually had a good fitting. So what they should be looking for at the end of a fitting, not just like, does the patient tolerate having it on, but what kind of actual functional things should they look for? The kind of clearances you need for housing. So whenever we have a split housing for a transhumeral, what are the appropriate clearances so that my device will function and I just don't have a ton of cable and no housing. Again, this is really for boards, right? Looking at our Munster, Autobuck, and Northwestern, and where would those be used, that style of socket. And then I focus in a lot on force and excursion problems. This is something that everybody in school had to go through. But how do you identify a force problem in both a transradial and transhumeral patient? And how do you identify an excursion problem? And then if you have identified it, how do you fix it, right? So with our transhumeral simulation, for example, students on practicals are basically given the simulation, and it's simulating one of these problems. So we can have basically the terminal devices opening before the elbows flexing, and they need to be able to tell me that that is basically a force problem. The forces aren't appropriate within the system, or the terminal device isn't able to fully open, and that's an excursion problem. So this allows them to practice, and also, again, this is reference for them. We do go through, that was all essentially body power and anatomically suspended. So we go through input mechanisms for externally powered, switches, force sensing resistors, linear transducers, as well as kind of your standard electrodes, including suction, and your floating or your snap or dome electrodes, whether you're looking at regular or you're looking at like coaps. Again, students get to fit dual site. They can turn off one of the electrodes and get into working with a patient with a single site as well. They get to fit the coaps, and we now actually, thanks to a grant, have access to a glide in-house, which we have not had before. So we do have a glide that we'll be able to introduce into kind of bridging that gap between single or dual site and pattern recognition in the future years, which I'm excited about. But I do want to really focus in on the students are not taken into, basically they're not educated on just memorizing componentry. So memorizing component names, I really feel like that's the stuff that they get out in clinic, and I'm happy to be proven wrong on that. But we take a very agnostic approach to manufacturers. So whenever manufacturers come in, so let's say Chris Bashik, he is extremely knowledgeable in upper extremity. He gives a partial hand lecture for the students, but he stays very agnostic. So he presents not just what Point Designs provides, but also what Naked Prosthetics or OSER now provides, and other options as well, Vincent Systems, etc. So I want the students to know all of their options, but I'm not asking them to memorize manufacturers. And all the manufacturers or content experts that come in follow that, which I'm very, very pleased with. All right, so I think we can bring Megan back in here now. The goal here, right? I'm going to skip right past that, is to foster discussion. So now that you've seen the ULO and ULP presentations, we're really just curious, what do you want residents to be able to do on day one? And what kind of guidance do you provide regarding both ULO and ULP, so we can kind of cater to that? And then I'm really quickly going to put our contact information up so you guys can get us. But after you've had like 10 seconds with that, I'm going to go ahead and stop sharing so I can see, well, I was going to say faces, but blank screens with names at least. All right. Yes, please, Yusuf.
Thank you, Jeremy. Very good, overall presentation on your project at Baylor College. I'm interested in knowing, is there like a project for the upper limb prosthetic for the students to do before they finish the course, or is it just the trainings and the theories that you give throughout the course?
Yeah, so all of the projects that I went through, they make a functional device, or they make a socket or the device. So the bypass device is functional. It is something that they wear and they utilize for a period of time when Sean comes in and talks to them. But as far as working with patients, they do fully set up the systems. So they set up the dual site and the pattern recognition systems with the Tasca, with the iLimbs. Nobody leaves with anything, right? But they do get the full.
Not even the mechanical, the mechanical prostheses. Patients don't take them home, or
No,
how are these like volunteers that they come to the college?
So we actually pay our patient models. They come in and they work with us, and they are paid patient models.
Okay.
We're not a clinic ourselves, so we can't provide anything.
Okay. Thank you.
Of course.
Hey, Jeremy.
Hey.
So one suggestion I have of something I think would be good to do that's also realistic is to have some practice sewing harnesses from scratch. I know y'all teach sewing. I mean, I learned how to sew there, but a lot of the actual like harness application, I felt I learned kind of through seeing patients. I mean, I think that's a good way to learn, but perhaps having a little bit of background before you actually get in there and you're not just trying random things, because that is a way to learn, but maybe it's not the most effective.
No, that's a great suggestion. Yeah. I mean, having been here, there's nothing that makes the students more afraid than asking them to sew something, but it's definitely something that is beneficial. Thanks.
Sure.
Hey, Jeremy.
Hey, what's up, Taylor?
I was gonna say I felt now and like seeing upper limb from the other side. I feel like something that was really helpful was just getting pocket design down at school. So then, like when I did go into residency, it was nice to just have like a basis for a fit. And then I feel like the alignment and all of that stuff, it's nice to have a reference, but like until you do it multiple times, you're not going to be like a pro at it. And I don't think the preceptors expect you to. But I feel like getting down socket fit was like a big help.
Thanks. That's really helpful. I appreciate that.
While people are thinking of their last minute comments, just a couple quick reminders. Make sure you take your CEU quiz for us. And then next month, you get to come back with Jeremy again, and Mandy are both going to be presenting on lower limb prosthetics. So that should be a good one, both trans-tibial and transfemoral and everything in between. Any last minute questions, comments, anything? Otherwise, we'll give y'all a few minutes back. Awesome. Well, thank you guys for coming today.